Welcome to our weekend wellness hour. Today we have a good friend of mine, Dr. Alan Shih, with us. And I met Dr. Shih about a year and a half ago through a friend, and we have attended some real estate investing conferences together. But one of Alan's specialties, besides looking and investing in real estate, is he is a podiatrist, a podiatric surgeon, and he attended the podiatric school at the Dr. William M. School of Podiatric Medicine, followed by an internship at the Tennessee Valley VA Medical Center and a surgical residency at the Southern Arizona VA Medical Center. He also completed the highest level of surgical training at a level 1 trauma center in Chicago, the Advocate, Illinois Masonic Medical Center. Dr. Shih also received advanced training at the Tucson Institute for Peripheral Nerve Surgery, which is an affiliate of the Johns Hopkins School of Medicine. So I welcome you, Dr. Shih. Thank you for joining us today. So please share with us a little bit more about kind of why you decided to dive into feet.
Yeah, I've always wanted to help people walk, and originally I wanted to go into physical therapy, but I think my personality is just I'm not all that patient, and so podiatry seemed to suit me a lot better.
Oh, that's wonderful. So you went to podiatry school first, and then you started diving into different internships and residencies. And so from there, how did you get into more of neuropathy and, peripheral nerve injuries? Was it just one of the residencies that piqued your interest, or how did that happen?
No, actually, so a lot of the nerve stuff that I learned was post residency, actually, and probably one of my bigger my mentors and higher influences, I think, sort of got me into peripheral nerves. And so it's kind of interesting. I did residency at a level 1 trauma center, and I had a big focus on surgery, and I learned a special technique in Russia, the Lazarov technique, and that's pretty advanced orthopedic stuff, and that was kind of the direction I was heading. But then I guess my mentor sort of opened me up to the world of nerves, which is something that really isn't focused on even in residency. I had quite a bit of training, but really the only thing that foot and ankle surgeons are trained on with nerves is essentially to cut a couple of nerves out between the feet, between the toes, essentially. Is kind of, and maybe tarsal tunnel every once in a while, but there really is pretty little focus in orthopedics and podiatry, generally speaking, about nerves.
Yeah. Can you share with our listeners what is tarsal tunnel? So I'm familiar with it with physical therapy, but some people may not.
Sure. Tarsal tunnel is similar to carpal tunnel. And so basically, carpal tunnel, most people are familiar with. There's a nerve that runs across your wrist. And so when that nerve gets pinched, you might have weakness in your fingers, you might have tingling, they might go numb. And so similar to the same thing can happen in the foot. It's kind of an analogous structure, and generally that's not as common as carpal tunnel, but along those lines.
Okay, and then obviously the ones between the toes that we often hear about cutting out is the term Morton's neuroma, right? That we often hear. Correct.
Yeah, and so another one of my mentors out at Johns Hopkins, he's the world's authority in peripheral nerve surgery, Dr. Alan. So he was kind of challenging some of his foot and ankle surgeons, like, why are you guys cutting out nerves in the foot? And I mean, this is a really bright guy. He's like head of neurosurgery and plastics at Johns Hopkins, right? And he's very well published. And so a lot of them, I mean, that's kind of what we were taught, and that's just kind of what we do, and we never really question him. But he's like, look, you would never cut out the median nerve in the wrist for carpal tunnel surgery, and so you would decompress it. So it's a nerve is being choked, so you release it surgically. You don't cut it out. And so, I mean, that was kind of an eye-opening just revelation and change. I mean, it's kind of goes against everything that we've been taught, more or less. But it started to make a lot of sense. And I'm like, I think that probably makes quite a bit of sense, that preserving the nerve, and because that same nerve that you cut out for pain is the same nerve that gives you feeling. So the people that cut out the nerve, maybe they're trading that really sharp jabbing pain for a numbness in the area, essentially.
Right. Yeah. And since things have shifted, have you seen more success in terms of, because I imagine if you cut off the nerve, there's going to be some repercussions in the foot if you're just chopping it off. But now if you're just decompressing it, taking away the tissues that's impinging on the nerve, have you seen differences in terms of outcomes for people?
Yeah, and so one thing that I guess the biggest thing you need to be aware of, because I would still say most foot and ankle surgeons cut out that nerve, is that you can get what's called a stump neuroma. So generally after surgery, you get better and that sharp pain is better, at least for a couple of years. But then peripheral nerves try to regenerate, and then so a lot of times they end up getting a pain a couple years later that's worse than the original pain. And so when you just decompress the nerve, then you don't have that issue, and you still have feeling. You don't have the numbness that that they typically do. And like another thing too is it's not how good of a surgeon you are. If you cut out the nerve, the blood vessels and the nerves are intertwined intimately, and so there's no real way to dissect that out. And so when you cut out the nerve, you're cutting out blood vessels at the same time.
And blood vessels that are needed in other areas of the foot or further down from the nerve.
Well, I mean, like other areas can take over, but it's still ideal to have the nerve that the primary source of blood flow to those toes.
Right, right. So and now you have your own practice in Tucson, correct?
Correct.
You have, right. And so what are some of the common foot or toe or maladies that people come in with?
I mean, we certainly see a lot of ingrown nails. We see heel pain, various types of just everyday fractures and sprains and strains. But I have a focus on neuropathy, so a lot of people kind of seek me out for the neuropathy component.
Mm-hmm. What are some of the common neuropathy conditions that you see? So besides the ones we mentioned.
Yeah, and so a lot of it is not, and when I tell, and so if you look at neuropathy treatments, there's generally not a lot that's offered, right? And so you can take Neurontin and anti-seizure medicine. Some people talk about Lyrica or Cymbalta are common ones. That's an antidepressant. A lot of times when you ask about neuropathy to doctors, they'll just shrug and they'll say, well, you can't do anything about it. It's just going to get worse. You know, you can take narcotics if it's really bad. And then just, and the other thing that's, I don't know if I think it's funny, but like they always associate it to diabetes, right? And so diabetes certainly can play a role in that. But it's kind of like, well, you have neuropathy, so you must have diabetes. And if you don't, then they're confused and it's idiopathic. They don't know, right? And so, Dr. Alan kind of, I guess opened my eyes to the idea that, look, if there's pain, there's a reason for the pain. You just don't know the anatomy well enough, essentially, kind of. And so there's something called RSD, which is basically an advanced pain syndrome, right? But his mnemonic for RSD is really stupid diagnosis. And his idea is like, look, they have pain. There's a nerve that's generating the pain. If you find the nerve, then you can find a way to take away the pain, essentially. And so I think the problem in healthcare and a lot of doctors are just they're kind of trained that, well, there's nothing you can do, and so automatically they just shut off their brain to the idea that something can be done to help with neuropathy. And a lot of people, so many people suffer from neuropathy, and so in just various levels.
Yeah, I know when I work with clients, I often see when people have any type of nerve issue, if you follow the nerve and look at the length of the nerve, we often think of areas of impingement just being kind of a junction between, and like your pec area for your arm or, your tarsal tunnel. But I often talk to people about how muscles, if they're in a contracted state for so long and they're so tight, they can also compress on nerves as well. And if you start turning off those muscles and teaching them how to let go, it often relieves the nerves and you see a difference in their nerve pain. So I'm very pleased to hear this. Dr. Dalton is really, really challenging everyone to look at the nerves in a different way and see, okay, where is the impingement, where is the compression occurring, not just in the common places that we might think of. That's amazing.
Yeah, I mean, it's pretty interesting. He's actually, so he's a hand surgeon. He's a plastic surgeon and a hand surgeon. And like, so he was doing, so it kind of came about, like, so he was doing he's doing carpal tunnel surgeries on many diabetics that had carpal tunnel. So he'd release the nerve and it'd be like, great, that helped me a lot, doc. And can you do the same thing on my feet? I was like, I'm a hand surgeon. but Dr. Alan, he's a very innovative guy. He's educator to some of the best and brightest, and obviously amazingly, probably just one of the smartest guys I've ever met. He's like, maybe there is something to it. And so he kind of, like, a lot of times they talk about like a glove or stocking distribution for neuropathy. And so he's like, oh, well, look, there's a few nerves in the hand, the median nerve, the ulnar nerve, the radial nerve, and the pattern basically makes a glove after you work on those three nerves. And so, and he's like, well, the foot's an analogous structure. And so he went to the cadaver labs or dissecting. He's like, oh, there's similar nerve sets in the foot that can be released that will kind of give you that stocking distribution. Yeah. Right. And so he kind of found those areas where it's likely to be pinched, and he did experiments on rats and where nerves were bound and unbound, and kind of just, and so he really broke it down. But just in simple terms, it's kind of amazing, because if you talk to, just when I talk to patients and you say carpal tunnel and then same thing can happen in the foot, they're like, yeah, that makes complete sense, right? And so, but unfortunately in healthcare or with a lot of other doctors, I think just the way we've been trained and conditioned, that's just not, it's a hard leap for doctors to make for whatever reason, oftentimes.
Yeah. So when people come to see you, is there any consistency in terms of their medical history that you see that leads them to a neuropathy? So we often hear diabetes, which you mentioned, that's a common diagnosis, but are there other conditions? Is there dietary things that you see that's correlated with neuropathy? Anything at all?
I mean, there are a lot of things that can cause neuropathy, and a lot of people, the first thing they think of is diabetes, but thyroid can definitely be a factor for diabetes or for neuropathy. I mean, heavy metals and diet can definitely play a role. There's viruses, and so different conditions can certainly cause neuropathy as well too. And so it's really kind of breaking it down into smaller pieces, because I think that's part of the issue too, that I mean, there's big nerves, there's small nerves, there's nerves that control your heart, your skin, your sweat glands. I mean, there's not nerves all over the place. And so until you start breaking smaller pieces, it's really hard to get traction on it. And so I think partly, since I focus below the knee, I think that helps me a little bit, that it's not like neuropathy everywhere. We're just, okay, so how do we kind of help with neuropathy on the top of the foot first, and then we can move to the bottom of the foot or in the leg. And so kind of, I think, break it down to smaller pieces. And like I said, it can be the small nerves in the skin. That's a completely different type of neuropathy, the small fiber neuropathy. It's kind of a different treatment for that. But like just starting with the anatomy, as far as understanding kind of what nerves to go to what areas, a lot of times is pretty insightful.
Okay. And then are there different treatments? So if it's the small nerves of the skin, how do you treat that versus maybe it comes from higher up and it's the tibial nerve that goes down, or one of the other big nerves of the foot?
Sure. And so one of the more successful treatments, I think, for small fiber neuropathy is called neuromodulation. Okay. And so that's a fancy word for nerve reprogramming. And so if you think about it, kind of on a grand scale, the nerves are basically our electrical system, right? And so if you were to, and so the visual that everyone gets and has seen before is when they take paddles out and they shock people's heart, right? And so they don't keep on shocking them, but right, it resets the electrical system. And kind of similar, we can do something similar to that with neuromodulation or electrical stimulation therapy. It's similar to a TENS unit in that it does use electricity, but it's also very different. So a normal TENS unit is about 0 to 2,000 hertz. This is 0 to over 40,000 hertz. And so it doesn't mean that it's an electrical chair or you're gonna, like, your hair is gonna stand on end, but just kind of cycling the nerves through these different frequencies, a lot of times it can get the nerves to kind of settle down. And I don't think most people realize, but I mean, the small nerves in your skin can be can be very painful. And so like, that's why you get a paper cut and there's no blood, and all of a sudden like it stings like crazy, but you don't even see like, how does it hurt so much? Because there's a lot of fine small nerves that are in your skin.
Mm-hmm.
So that certainly can be a form of neuropathy that can impact a lot of people.
So then do you also have people do blood work to check to see if it's a thyroid issue as well?
On occasion. I mean, I wouldn't say that's so much my focus, just because that's usually more the realm of the primary care doctors to kind of check that stuff. And usually, I mean, if there's a high suspicion, then I bring it up, and they kind of usually talk that over with their primary care doctor. And when they get other blood work, then they can try to get a thyroid panel and those kind of things. But so on occasion, but not generally speaking.
And then the neuromodulation, is this something they do in the clinic, or is this something that they take a machine home to practice it on a daily basis?
The one we have it's in clinic. And I'm not sure that they're truly home-based options. There's only a couple in the state of Arizona. They're not a lot. It's not a super popular treatment, but it's a pretty powerful treatment. I've had patients that have been to like pretty prestigious places like Mayo Clinic and Barrows Clinic in Phoenix, and have gotten some pretty substantial results with the neuromodulation. So it's certainly a good tool.
Yeah. And then for some of the deeper nerves, are there other treatments besides surgery first, or is it kind of like surgery is the mainstay?
And so certainly some of my mentors like Dr. Dallin have a very high surgical focus. I guess I've sort of blended that and just understanding the anatomy. And so the first step is identifying the nerve. And so, I mean, a lot of times just resetting the nerve, putting some medicine close to kind of calm down the inflammation next to those nerve spots where the nerves being, and so kind of describe it as, like if you're being choked, right? You might get lightheaded, you might get weak, you might feel sick, right? So if a nerve gets choked, it might tingle, it might burn, it might cause weakness, all those kind of things. And certainly it kind of depends on the extent of how badly it's being choked, right? And so I'd say for most people, if you reset these areas, they can do pretty well. And there's multiple sites that these nerves can be compromised, but a lot of times you reset, and I'd say surgical isn't a huge, I mean, it's there for the patients that need it, but it's not most patients, I would say. And so, but it also, and so patients, for instance, that we put the medicine and they're like 90% better or 100% better for 2 days, and it's back. And then, well, that's good in the sense that we at least identify the nerve that's compromised, and then they can feel more I can feel more confident too that if you go to surgery, you have a good chance to get better. And so I think the first step is identifying where is the problem coming from, and that's usually conservative first, and then if surgery is needed, and on occasion it is, and that can be done. But so a lot of people will do like NCV testing and EMG testing. There might be some value with that. I mean, generally EMG testing, that's not, for most patients, it's not really the issue that most patients have. And NCV testing can give you some insight, but it's still really not all that therapeutic for most. It's not therapeutic in that it doesn't help them, but maybe it helps identify the region a little bit more.
Right. And some people, when they have information, that helps calm them down a little bit. So I can see some people really like to have that testing done on their muscles and nerves just to find out yay or nay if there's a problem. So I can understand that. Do you also discuss with your patients about lifestyle changes, whether it's footwear or how they carry themselves, anything like that you have seen that can truly impact these types of nerve injuries or disturbances?
Yeah, I mean, certainly, because there's certainly a mechanical component to nerves as well, let's say. And so for instance, like a lot of times you'll see one of the conservative treatments for carpal tunnel are braces to kind of make sure that you're not overstretching that nerve that goes to the hand and fingers. And so kind of the same thing too is like orthotics to kind of control the motion, how much the foot, part of the foot's function is to absorb shock. And so you want some of that, but to kind of control excessive motion is important. and overstretching, let's say, the nerve as well as tendons. And so, and then also if you have better support from other ligaments and bones, then you're putting the nerve at less, I guess, compromise or irritation.
All right, that makes sense. How much, so when you do orthotics, how much do you look at their shoes as well? Because I know there are such a wide variety of shoes out there, and people wear heeled shoes or dress shoes. Do you try to encourage them to get into more lace-up, athletic shoes that are more cushioned?
Yeah, you have to listen to the patient, right? And so a lot of it is, if they're never going to wear a running shoe, then you don't have to have a huge discussion on it, I suppose. And like, if they're only going to wear sandals, and that's common in Arizona and Tucson at least, and then you have to kind of figure out something that works for them. And so, I mean, a lot of times, generally speaking, I like running shoes. They have a lot of support, a lot of cushion. They're not great if you're going on side to side and playing tennis, I suppose. But for most people, they work pretty well, and you can definitely get a custom orthotic in. But really, it also has to be something that the patients are going to wear. Otherwise, it's not. It's more academic than anything.
Yeah, absolutely. So now I know you collaborate as well with the University of Arizona Medical Center, correct? Are you still doing that collaboration?
Yeah, I've done more in the past.
Okay, more in the past. Okay. Was that centered around nerves or another area of study?
We've done some different things. And so, like one was on fungus, another one is on temperature of their skin on the foot, and so pressure spots. And so kind of one of my mentors, who's now at USC, has kind of a huge focus on wound care, which I wouldn't say that I have a huge focus on at my clinic, but I've certainly worked with them in the past.
Yeah. Now, do you see some athletes, right? You see some sports injuries at your clinic?
Sure.
Now, how big is fungus of the toenail? How big of a problem is that?
Well, it's pretty common. We see it. I mean, obviously, I see it daily and frequently daily. I think there's some statistic that 50% over the age of 40 have it, and so it's a big thing. And we have laser treatments for it, and we I don't know if it's a specialty, but it's certainly something that we focus on, or something that we treat a lot of. And one thing that, even though so just for treatments of toenail fungus, there's a laser that you can use that's the most effective. There is an oral medicine that does affect your liver that can be effective. There is removal of the nail, and then there are topicals, which generally are the least effective. So those are your 4 treatments, regardless of where you start with those treatments. But one important thing is trauma to the toenails. And so so the incidence of toenail fungus is very common, but it's much more common than fingernail fungus. And they're basically similar structures, but the environment's much different. Toenails, they're in shoes, which are warm, dark, and moist. So everything fungus loves, plus a lot more trauma. And so generally you don't see it in people's hands. If you do, it's maybe they smash their thumb in a door with a hammer, or maybe if they do a lot of digging kind of stuff with their fingers, then they might be a little bit more susceptible. Generally, you don't see it too much in the fingers. But toenails, and a lot of times it's the trauma that kind of starts the toenail fungus to start. And so oftentimes it starts in the big toe, and all of a sudden it's on the second, third, fourth, and then just kind of carries through. And so limiting trauma is a big component of trying to improve toenail fungus. And so a lot of times it's not necessarily the shoe's too small. I mean, certainly that's a problem. If the shoe's too big and your foot's pisting back and forth, that's a problem too. I like custom orthotics that fit the foot well. Ideally have maybe a little bit more of a suede type material to kind of create a little bit of drag, so it's less likely to hit the front of the shoe. I mean, the other big component is that it's not the shoe. It typically fits right for many patients. It's just that what happens is when they step down, the foot expands. And that's why it hits the end of the shoe. And so if they can get a good orthotic that keeps their foot from expanding as much, then it's less likely to cause trauma hitting the end of the shoe.
Got it. And then I know I've heard so many stories about this fungus is hard to cure. Obviously you have some different treatments, but are there cases where like what will happen if it doesn't get under control? Let's say someone doesn't seek treatment. What will happen if it goes to all 5 toenails? Will eventually lead to more dangerous conditions?
So for toenail fungus, it's like if you have fungus anywhere else, like in your lungs, you treat it typically. Toenail fungus, and there's the argument: is it cosmetic? Is it medical? I mean, you can argue both. And so that's part of the reason the insurance companies don't pay for the laser treatment, because they say it's cosmetic, right? But then there's definitely an oral medicine you can take. And there's definitely medical codes for toenail fungus. Onychomycosis is the technical term for it. I guess going back to you're talking about what was the question again? I'm sorry, I got off track.
What will happen? No, it's not fine. What will happen if you let it go and you don't get it treated? Like, is it going to become systemic, or your toenails just fall off? Like, what will happen?
That's right. Sorry. And so toenail fungus, there are a lot of elderly people and somewhat immunocompromised, and like I said, there's a lot of toenail fungus. A lot of people have it, and so generally speaking, you're not really going to have an issue as far as like if it's a bacterial infection, much different deal. You definitely need to get it taken care of right away. You could lose your leg and life, and
Yeah.
for sure. Toenail fungus, generally speaking, is not something that leads to people's demise. Just oftentimes an emotional thing, and the people with like the worst toenail fungus and the worst toes that really don't care, and others just mild, almost nothing, you're like squinting, and they're like all worked up about it. So toenail fungus is something that is probably ideal to treat, but it is not the same concern as, let's say, a bacterial infection.
Okay. So when you do the laser treatment, how often do you have to get that done?
There are different lasers and there are different treatments. And so our treatment is usually we do 3 treatments. And so there are studies that show multiple treatments are more effective. And so generally ours are 3 treatments, usually 2 to 4 weeks apart. And so, we usually tell patients too, and so whatever treatment you choose, the toenail takes a year to grow out. Maybe that's on the conservative end, but it takes a long time. So you won't see any differences walking out. And so it's the fungus that's there doesn't go away, it grows out to go away. And so you have to wait till the nail actually grows out. And so that's why it takes several months to see an improvement in the toenails. And ideally, a few months later, you're looking to see the new nail coming out looking clear, and then the thicker yellowish nail to grow out.
Got it. So then also, what are some of the other repercussions? Do you change shoes? Do you change their socks? Anything like that?
Yeah, and so you want to combat moisture and darkness. And so I suppose from a toenail standpoint, like open-toed shoes are good, and it's more open and airy. I think that may not be practical for some people. And so if you can shoes that breathe better, so like a running shoe is more ideal than a closed leather shoe, and like a cotton polyester socks is better than one that's just all cotton. It absorbs a lot of moisture. Generally, like white socks are better than darker socks, just the dye, and so they breathe a little bit better and wick a little bit more moisture. So those are definitely considerations.
Okay, and then anything with the diet that they should change that you've noticed?
Certainly optimizing diet is a good thing. I can't say that's a huge talking point when it comes to toenail fungus, but certainly optimizing diet, I'm sure, and taking up sweets, I'm sure is helpful for that. I'm not all that aware of studies in that regard.
Got it. Awesome. So the other thing I was going to ask you a little bit more about is kind of bunions and hammer toes, and do you see that pretty often?
Sure.
Yeah. Any reasons why those develop, especially bunions? I know those take time. Kind of the big toe starts to deform a little bit. Bunions develop. Have you seen any studies, or in your experience, is it related to shoe wear, the way people position themselves? What have you seen?
Shoe gear is certainly a factor. Genetics is certainly a factor. Like if you have a lot of laxity in your joints, then you're probably going to be a little bit more susceptible. kind of the shape of the bones is certainly a factor as well too. So if you, it's a little harder without showing an X-ray, but if you have like a square bone, let's say, then it's just more mechanically sound and less likely to deform into a bunion versus, let's say, it's like a round head. Then it's easier for the toe to drift over.
Got it. Okay. And then again, do you try conservative methods to help the bunion first before you do surgery? Is that?
Yeah, I mean, people ask about spacers and splints, and you can use them, and if they're certainly not going to correct the bunion, and bunions really, the decision to do surgery is based on pain level. And so we'll have patients that have overlapping toes and they're like, it doesn't hurt me, we leave it alone. Others that have a tiny little bunion and they're like, it hurts, I can't get shoes on, and we end up doing surgery. And so conservatively, orthotics are useful to at least discuss, and they're not going to correct the bunion, it's not going to take the bunion away, but potentially keep it from getting worse by kind of controlling the mechanics. You just lessen the deforming forces, but it's certainly, it's just not going to correct the actual bunion.
Yeah. And then with hammer toes, that's something that also comes on over time, correct?
Correct.
And with people that have hammer toes, do you see a lot of tightness in their calf muscles that leads to the tendons pulling abnormally on their toes? Or is it something that the formation of their foot? What do you see that's the common cause or contribution?
Sure. And so hammer toes are super common. Pretty much everyone has hammer toes. It's like, for the most part, most people have them. Tightness in the calves is just all too common and certainly a factor. The reason you get hammer toes is the tendons on the bottom of the foot pull harder than the tendons that pull up on the foot, or on the toes. And generally it kind of has to do with mechanical advantages, like a pulley. If just usually the foot tends to collapse, and when your foot tends to collapse, then the tendons that pull down pull stronger. And also partly too, not just, so kind of a continuation with hammer toes, a lot of times that fifth toe, that pinky toe, is almost pointed sideways, not just down, but also towards the big toe. And so that's kind of a reflection of the tendons that pull down, and then because your foot rolls over, that just I guess the angle of pull, it tends to pull that fifth toe more towards the big toe.
Yeah. And which can be a problem as well. And I have seen people who've gotten surgery to correct it, but I also see a lot of people who have it who don't need that surgery, that they can get away with changing their footwear, right?
Yeah, and hammer toes are similar to bunions are similar to bunions in that it's really based on pain level as far as if you need to address it. There probably are quite a few hammer toes that you can address just like with a small incision to release the tendon that pulls down and not actually have to go into the operating room and cut bone out the more traditional way.
Mm-hmm. Yeah, so very fascinating. What are any other conditions that you see often that you could provide some education on for people to consider?
Yeah, a lot of it is, so a lot of times patients come in and they have no idea some of the opportunities that are available. Like a lot of times resetting some of the joints in the ankle or a joint underneath the ankle, the subtalar joint. We can get people to pull up their foot quite a bit stronger and have much better range. And so it's very, very rampant. But I guess most people aren't really focused on it. Most people don't know. And a lot of times they'll come in for toenail fungus, right? And we'll start looking at, and we'll start examining them, and we'll look at other things. And then I'll ask them, like, are you a little clumsy, or how's your balance, or do you shuffle your feet? Oftentimes the spouse is like nodding their head, and a lot of times resetting some of these areas that are inflamed and irritated can just make a pretty profound difference. And so it's not, so sometimes patients will have a history and they'll say like, yeah, that ankle's just been a little bit weak. I sprained it 20 years ago. It's just never been the same. And, I've been to the ER, I've been to doctors, I've gotten an x-ray, I've gotten an MRI, and there's nothing wrong with it. And a lot of times, and that's kind of where nerves come back into play, is like, a lot of times it's not that it's a torn tendon or a broken bone. A a lot of times nerves in the area are inflamed and irritated, and so your body doesn't like pain, so it kind of guards the area, so it's a little slower. It doesn't quite pick up very quickly. It loses range, and these impact people, and so a lot of times resetting some of these areas in the joints, and then also working with physical therapy can make a pretty big difference for patients to really reduce their fall risk quite a bit, and just move a lot better.
Yeah, yeah. Now, when you reset the subtalar joint, do you do that yourself in clinic manually, or do you send them to physical therapy?
Yeah, so usually I'm doing it with injections, typically putting medicine there to kind of calm down the inflammation, irritation, and I don't do a lot of therapy. So there's actually a therapist next door to us, and we send them a good amount of patients to kind of help with.
That's amazing. That's great. It's wonderful. What are some of the common sports injuries that you see?
Common sports injuries. I mean, the tendonitis. So there's a big tendon, the tibial tendon, that kind of helps hold up the arch. So sometimes people will lose push off on their foot, and so that's a pretty common one, right? And so that's, whether it's an athlete or not, that's a pretty common injury, I would say. Plantarfasciitis is another one that's similar along those lines. Those are some pretty common ones.
Yeah. What are some of the successful treatment options for plantar fasciitis that you guys have employed?
Yeah, so usually like calming down the area with an injection typically, and then orthotics is I'd say the mainstay for most patients. Certainly like stretching and night splints can be helpful, and there's a whole bunch of things like amnio and like kind of a stem cell type treatment, and we have lasers, and there's more and more advanced things that you can use, but I'd say that the bulk of patients get better with good custom orthotics and kind of just decreasing the inflammation in the area.
Yeah. Have you seen a lot done in the foot with stem cells?
I mean, it's certainly growing. It's certainly the interest. There's areas that I think it makes perfect sense. Like, and stem cells is kind of a term that maybe you're not supposed to use stem cells. Like, so one of the more common things that has a strong parallel with stem cells are called are amnio injections. And so, without getting too technical and stuff, it's a regenerative type treatment, and so some areas like the Achilles tendon is a perfect area to use it if that's an area that is oftentimes somewhat doesn't have great blood supply, and so it's difficult to heal sometimes. So certainly that can help augment healing. And some people like to use their own blood and their own growth factors. So some people like PRP, or the platelet-rich plasma, opposed to the amnio, but the amnio tends to have much higher regenerative skills, just because as you age, I mean, even when you're 18 compared to when you're 2, your growth factors drop off pretty dramatically, and so oftentimes the amnio is and the nice thing is too, you don't have to draw your own blood, and some people get freaked out about drawing their own blood, and so that oftentimes is a good option for patients.
Yeah, that's amazing. So any other last things that you would like to share with us? Any stories of some major success patients that you have, just some different things that people can learn?
I think the biggest takeaway, and then we've had some dramatic things, like one was like an 18-year-old in baseball scholarship, right? Pick up his foot after a foot drop, and then just releasing that nerve allowed him to regain full recovery, and that's a pretty special thing, I guess, in my mind. But even just every day, just a lot of times on a smaller scale, not as dramatic as that. That's pretty dramatic, and college athlete, but like day to day, just helping patients pick up their foot a lot better, because a lot of times it's so common that like you start probing them, and then you show them that their foot's a little bit weak in picking up, or the rotation, and then, oh, you fell recently too, right? Or you fell, and so those go on to help people quite a bit more than they realize. And so it's not as dramatic or as glorious as working on a college scholarship athlete, but it's pretty cool and pretty dramatic. And a lot of times too, if you work on just, it changes. I mean, you see the difference in the patient, just you get them to move better, and all of a sudden everything changes for them. I mean, so it's pretty dramatic. And that's like, bunion surgery is cool and stuff like that, but like the stuff with it's a different story that you get from neuropathy patients when they start to get improvements there, because it really is life changing. And so I think the biggest key is I think my biggest thing I'd like to impart is that there's definitely things that can be done. But I tell patients when it comes to neuropathy, it's not nearly as tangible. If we're going to cut a piece of bone, then we can look at that together, and we can, okay, I'm going to put screws here. That's very tangible. If we're going to shave down bone, that's very, very tangible, and you can see it together. Neuropathy is, there's definitely things I tell patients, there's definitely things that we know. There's definitely, we know the anatomy, that kind of thing. But then it's a little bit of an art and maybe a little bit of witchcraft. There's things that can work, but it's just not as, it's not as clean cut as some other areas of medicine.
Yeah, that makes sense. And it takes so long for nerves to regenerate and grow that I guess I imagine that also plays into part where you can relieve a nerve, but then if something's damaged, it takes time for it to really heal as well.
Yeah, and that's actually one of the exciting things. Like, so I work with peripheral nerves, and people are like, what's peripheral neuropathy, right? And so they hear that term, and so okay, so central nerves are basically your brain and spinal cord, and the thing with those nerves is those don't regenerate. So Christopher Reeves, when he fell off his horse and he injured his spine, it's not coming back. The great thing with peripheral nerves, or the nerves that go to your legs and feet, is that those nerves can regenerate. And so slow, and certainly not an overnight thing, but they at least have that ability to regenerate, which is great.
All right, it's amazing. So now you have a clinic in Tucson. Do you do any virtual visits, or do people need to come see you in person?
Yeah, it's pretty much in person. It's difficult to actually do a true evaluation virtually, for me at least.
Yeah, and that makes sense. I mean, you have to see how they're moving, and especially if you're dealing with their nerves, to be able to assess their nerves. So how can people reach out to you? Do they want to come meet with you, get an evaluation? How can they reach out to you?
So I'm in Tucson, and so the website is tucsonfoot.com.
Okay.
And my office number is 520-545-0202.
Wonderful. Thank you. Because I know some people listening, they do have some issues with their feet, and I know they could really benefit, especially because some of it is nerve issues that many doctors in the Phoenix area have not been able to figure out. So I know that you could provide a lot of help for quite a few people. And Tucson isn't a far drive from Phoenix, only an hour and a half or so. So it's not a bad drive for meeting with a specialist like you. So we appreciate that. So thank you for coming on today. I really appreciate all the information you provided everyone on foot care and just neuropathy, and how people can, consider their options for when they're having some issues with their foot or ankle.
Thanks for having me.
Yeah, thank you. Well, all of you guys, thank you so much for joining us today. We will see you again next week for another episode of our Weekend Wellness Hour. Have a great weekend, and we'll see you again. Bye.